I have been working with an intervention to reduce child mortality for some time now that involves the mass administration of azithromycin to specific age groups in high mortality settings. Today, I will go through a little bit of the history of this intervention and then focus on what we know today about its risks and benefits and where we see the next steps for the future. To anchor the talk, I wanted to begin with the Sustainable Development Goals. We are all well aware of the importance of child mortality, specifically as an indicator of public health success or public health need. And to that end, the Sustainable Development Goal number 3 sets specific targets for the reduction of preventable under 5 mortality by the year 2030, specifically to less than or fewer than 25 deaths per 1,000 live births. These maps show trends in under 5 mortality in sub-Saharan Africa from the year 2000, which starts here on the upper left, through 2005, 2010, and finally in 2015. The areas in purple are those that have already reached the Sustainable Development Goal target of 25 or fewer deaths per 1,000 live births among children under 5. The yellow areas show under 5 mortality of around 50, or twice the SDG target. And then the dark red and orange areas are those that have U5MRs of about 100, which is 4 times the SDG target. And we can interpret that as meaning about 10% of children will die before their 5th birthday. And finally, the darkest red areas that we see in the past, in the year 2000, these had U5MRs of greater than 200, or 8 times the Sustainable Development Goal target. So we can see that in 2000, under 5 mortality was very high throughout West and Central Africa in particular, and that we've seen substantial progress over time through the year 2015. However, you can also see in 2015, only a few of these areas had actually already reached the SDG target, and that many subnational settings, particularly in West Africa, had persistently particularly high mortality rates of around 100 under 5 mortality or more. Given the ambitious SDG targets and the persistently high rates that we're seeing in some settings, there is an urgent need for highly effective and feasible interventions. And so the child mortality intervention I'll be discussing today was originally used in the context of trachoma, a blinding infectious eye disease. The World Health Organization currently recommends the SAFE strategy to control trachoma in endemic areas. SAFE consists of a package of different interventions to address different phases of the disease from prevention through treatment. The A in SAFE stands for antibiotics. The WHO recommends that trachoma endemic areas receive 3 to 5 years of annual mass drug administration with azithromycin, which is a broad spectrum antibiotic. This means that everyone over the age of 6 months in a community will receive that antibiotic once a year, regardless of whether they actively have the infection or not. This intervention has been shown to treat both active infection and reduce transmission quite dramatically, and it has proven to be very effective in helping countries achieve their goals of eliminating trachoma as a public health problem. Our group has long researched azithromycin mass drug administration for trachoma in a range of different settings with different goals. And in the course of that work, we started to see that these distributions were having other impacts as well. One of our trachoma studies included mortality among children 1 to 9 years old as an outcome so that we could examine this question further. The paper shown here reports a cluster randomized trachoma trial that compared annual mass azithromycin to delayed treatment in 48 communities in Ethiopia. After 1 year, we saw a dramatic 50% reduction in mortality in communities that received azithromycin compared to delayed treatment, which was a truly remarkable effect size. Since we know that azithromycin has efficacy against pathogens responsible for the common causes of under 5 mortality in this setting, including respiratory infections, diarrheal disease, and malaria, and we have seen similar reductions with azithromycin distribution elsewhere, these were considered the plausible mechanisms. However, this study had a small sample size and was flawed in a number of ways, but an important flaw was that the comparison group did not receive any intervention. So it is possible that simply the presence of the study team in the azithromycin distribution arm contributed on its own to lower mortality. So based on these results, which were considered hypothesis generating at the time, our group was then funded to continue this work to directly study the impact of these distributions on mortality, this time in a higher mortality setting that was not endemic for trachoma. And so this was called the Mordor trial, which was a cluster randomized trial of biannual, meaning twice a year, azithromycin or placebo mass administration over 2 years in 3 countries, in Malawi, Niger, and Tanzania. This figure shows the primary mortality results after 2 years of distributions. On the y-axis here, we are looking at the percent change in mortality in the azithromycin group compared to placebo. So the positive number here, positive numbers indicate a reduction in mortality in the azithromycin arm compared to the placebo arm. Overall, when combining the 3 countries, we see a 14% reduction in mortality in the communities that received azithromycin compared to placebo. And in Niger, which had the highest background mortality rates, this was an 18% reduction. We do see effect sizes in Malawi and Tanzania and parts of their confidence intervals, which are also consistent with a benefit in those settings. But because those countries had much lower mortality rates than Niger, we were unable to detect these site-specific effects. This figure shows the Mordor results by subgroups defined by age. In particular, we have age groups of 1 to 5-month-olds, 6 to 11-month-olds, 12 to 23-month-olds, and 24 to 59-month-olds. We can see that overall, and in each country, the strongest effects were in the 1 to 5-month age group. And then in Niger, we see this consistent stronger effect in the 1 to 11-month age group. Again, I do want to mention that because mortality is a relatively rare event, even in a high mortality setting, you have to have a very, very large study to have power to look at subgroup effects. And so even though Mordor was quite large with 1,500 communities, we didn't have much power to look at subgroup specific effects. And so again, these results were hypothesis generating, leading some to conclude that the intervention may be more effective in the younger subgroups, but this was not a definitive result. After we completed the Mordor 1 trial, which looked at the first 2 years of distributions, all communities in Niger that participated in the study, they then received 1 year of 2 biannual azithromycin distributions. And so in this follow-up study, we continued to monitor mortality. In this graph that I'm showing, you see first the results from the first 2 years before everyone received treatment. We're looking at mortality rate in each arm, with the red being azithromycin and the blue being a placebo. And then each time point here is a mortality measurement period of about 6 months. Before I show the rest, to show you what happened after we treated everyone, I'll share that we had a few specific questions that we wanted to answer with this follow-up study. One question was, will we see mortality drop in the former placebo communities? And so here we see this higher mortality in the placebo communities. And if we see mortality decrease once they receive azithromycin, this would be an additional confirmation that the intervention is effective. Another question we had was, would we start to see the lower mortality in the azithromycin communities? Would we see that effectiveness of the intervention start to wane, or would we see mortality increase, perhaps because of an increase in antimicrobial resistance? And so here are the results. We do, in fact, see that when the placebo communities begin to receive azithromycin, their mortality quickly drops to the level seen in the communities that had been receiving azithromycin the whole time. And in the azithromycin communities that received azithromycin for the full 3-year period, we see pretty consistent lower mortality across the board, providing no initial evidence that resistance is causing effectiveness to decrease. Another question that arose with this work is about mechanism. Given the evidence that these distributions are reducing mortality, exactly how are they working? In this study, we conducted verbal autopsies on all of the deaths reported in the Niger site. Verbal autopsy involves an interview with a child's caregiver about the symptoms that were experienced before death to help determine the cause of death. Here we were able to include just a a few more than 90% of the deaths in Niger for this study. And here we can see the different causes of deaths that were identified on the left and the comparison of cause of death in the azithromycin versus the placebo communities here on the right. Points that are to the left of this dotted line mean that azithromycin reduced mortality from that cause compared to placebo. And so you can see that we did find statistically significant reductions in deaths from malaria, dysentery, meningitis, and pneumonia, with some evidence that mortality from other infections and diarrhea were also reduced in the azithromycin arm. And we see no evidence of effectiveness in mortality from malnutrition, measles, or pertussis, among a few other conditions. Another way our team has explored mechanism is through studies of the microbiome. A subset of children in the MORTAR trials provided rectal samples, and our team used metagenomic deep sequencing to examine the gut microbiome in children from the Niger and the Malawi sites. In both sites, we didn't see much of an impact of azithromycin on the overall structure or composition of the microbiome 6 months after the last distribution. We did see differences in specific organisms, however. In this particular study I'm highlighting here, we found a strong significant reduction in Campylobacter species in particular, known to cause diarrheal disease, which of course can be associated with mortality in this setting. And so far I've covered evidence on the benefits of this intervention. So now I'll spend a little bit of time on the risks. In terms of safety, we have extensive safety data on azithromycin's use in children 6 months and older that describe how well it is tolerated and that side effects are typically mild in nature. There is quite a bit less data on children under 6 months, so a lot of our safety-focused work in the course of these trials has focused on that younger age group. In the MORTAR Niger site, we did a survey of caregivers of infants or children under 6 months of age in the azithromycin and placebo arms to see if azithromycin was causing excess or severe side effects. Overall, we were unable to detect a significant difference in reported adverse events between arms after adjusting for multiple comparisons. In fact, there is a suggestion that some of these events, like diarrhea or vomiting, were actually greater in the placebo arm, potentially some signal of azithromycin's effectiveness for GI conditions in this population. Another important risk of this intervention is the potential for increasing antimicrobial resistance. Although the trachoma program has not systematically included monitoring of resistance, the studies on azithromycin distribution for mortality done by our group and others, they always have. And so here we see results from the MORTAR Niger site comparing the carriage of macrolide-resistant pneumococcus between arms. Here we do see a significant increase in macrolide resistance in the azithromycin compared to placebo communities, from about 2.9% in the placebo group to 12.3% in the azithromycin group. In this study, we did not see any evidence of an increase in resistance to other classes of antibiotics in the azithromycin treated communities. We also used metagenomic deep sequencing to compare genetic determinants of resistance in the gut. And again, we see an increase in macrolide resistance determinants in azithromycin communities compared to placebo, but not in other classes of antibiotics after 2 years of distributions. Similar work was done in the Malawi site in the MORTAR-1 trial. Here we're looking at macrolide resistance determinants in azithromycin compared to placebo communities on the left here. And we do see an increase in the proportion of macrolide resistant bacteria in azithromycin compared to placebo communities. The figure on the right suggests that this resistance may decline over time. We see this higher median resistance 6 months after the last distribution and a notably lower proportion of resistance 12 to 24 months after the last distribution. In Niger, we continued to treat and follow communities over 5 years to monitor resistance in the azithromycin and placebo communities. The top row of results here show macrolide resistance in particular, and we can see this consistent higher presence of macrolide resistance determinants in the gut in children in azithromycin compared to placebo communities. Importantly, we are not seeing evidence that the prevalence or load is continuing to increase over time, rather that it's staying at about the same level up to this 5-year time point, suggesting that it may saturate once it reaches a certain time point, which could make sense given the very small proportion of the entire population that's being treated. This series of studies, importantly, also suggested that these distributions might be increasing beta-lactam resistance as well, which would, of course, have important consequences. However, this was only suggested after 3 and 4 years and was not seen again at 5 years. And so this remains an open question of investigation in this body of work. In September 2020, the World Health Organization released guidelines on this intervention. They recommended against universal implementation, but their discussions included the importance of interventions to reduce mortality in very high mortality settings. And they ultimately determined that the potential mortality benefit outweighed the uncertain impact of antimicrobial resistance from these distributions on mortality and morbidity in the future. And so the recommendations specify that high mortality settings and sub-Saharan African settings in particular might consider this intervention as long as mortality and resistance are continued to be monitored, and only in settings where other child survival interventions are being concurrently implemented and strengthened. In particular, they're thinking of seasonal malaria chemoprophylaxis. In addition, they restricted the eligibility of children to those 1 to 11 months of age instead of the full 1 to 59-month age range that was treated in the Mordor trial. This choice was made out of a concern for increasing antimicrobial resistance. They wanted to reduce the amount of antibiotics being distributed by limiting the intervention to a particularly high-risk group, which they chose the youngest children in this case. Today, there are at least 10 major projects ongoing throughout the West African region to continue to examine questions on effectiveness, mechanism of action, antimicrobial resistance, impact on the microbiome, and implementation research around this intervention. Several of these countries are poised at this point to expand their work into national programmatic implementation over the next few years or so. And some of the biggest questions are currently how to continue to monitor mortality and antimicrobial resistance in a large-scale programmatic setting in a way that provides information that is useful for decision makers, but is programmatically feasible. And then, of course, there is this ongoing debate around how to balance the trade-off between the mortality benefit apparent with this intervention and the risk associated with how these distributions increase antimicrobial resistance.
Could I ask, are there plans to do sort of long-term monitoring specifically of carriage of gram-negative bacteria in relation to the beta-lactams, ESBL, that kind of thing?
That's a great question. In the Niger site in particular, we do have a group of communities that have been treated during the original Mordor trials for that 5-year period, and then have continued into another trial that has been involving distributions in the same area and others over the last 2 years. And so we have a group of communities with these very long-term distributions with particularly active antimicrobial resistance monitoring, including for co-selection of resistance in other classes as well. And I believe every country that is implementing these distributions is monitoring for resistance in macrolides, but other classes, including beta-lactams as well.
Excellent. Damali, do you want to unmute yourself?
Thank you, Kieran, for a great presentation. Very interesting findings. 2 questions. One, I could have missed. I just wanted to know the dose of the azithromycin that was given, considering, adherence to antibiotics, especially when you're not ill. I mean, I'm a clinician, but it's hard for me to complete a dose of antibiotics for, infections that I do have. But I wanted to know what people's experience was with adherence, feasibility and acceptance of this intervention in all age groups? And yes, did people really adhere? Because even if they did not take a complete dose, if it's not a single dose, then that drives resistance even, more. So there's that. And then two, I wanted to understand how you thought the azithromycin went about the mechanism of azithromycin reducing all these infections across the board, right from malaria to diarrhea infections. What mechanism do you think underlies that? Thank you.
Great, thank you. So for the first question around dose, that definitely a gap actually in my presentation. So we used the original trachoma program dosing of 20 milligrams per kilogram, weight-based dosing, up to the adult dose of 1 gram. It's administered as a single directly observed dose by the study team or the community health worker involved in the distribution. So a single dose 2 times a year that's directly observed. And so in that particular instance, there aren't adherence issues because if they agree to participate, then the dose is given right there. For the trachoma program, height-based dosing is used, and there is a poll or a tape that is used for different countries based on the distribution of their heights and weights and appropriate doses. And so we're using Niger's trachoma programs, Niger's trachoma program height-based dosing pool for children that are 12 months and older. And then for that younger age group, we're using hanging scales to determine a weight-based dose. In terms of feasibility and acceptability, the trachoma distributions, and as we found, these distributions tend to be highly acceptable and quite feasible given the existing campaign-based infrastructure in these settings and the familiarity with the type of mass drug administration campaign that is used for neglected tropical diseases. We find that coverage is about 95% in most of the studies that we have been working with. As for the question about mechanism, I mean, I think this is one of those really big open questions in the field currently. And so I think our work has suggested a few pathways through specific infectious diseases that may be particularly associated with under 5 mortality. And our group has focused on larger scale trials with a little bit less ability to do extensive mechanism focused work. But within that list of studies that I mentioned, there are studies that have dedicated quite a few resources to investigating that a lot closer. And I'm sure Julia and perhaps Nigel could speak more to that.
Wonderful. So we've got Gareth as well, but just before we go to Gareth, we have a question in the chat where Cinta asks, you presented no effect on age-related mortality in Wardour, and she's wondering whether this could be because of a low prevalence of HIV positivity in this population, and asks whether you have any other comments related to HIV positive infants and children.
Great question. I think you hit at the answer that the prevalence is just quite low in this population. And so there just wasn't enough information to determine whether or not there is an effect or not.
Perfect. So Gareth, do you want to close the discussion?
No, I just had a quick question really about the cost benefits, because presumably that's a fairly critical issue in terms of WHO's implementation plans, and I imagine that also depends on existing child mortality rates. Can you just tell us a little bit about where that has got to?
Definitely. So for this intervention, I believe all of the countries currently implementing this work are doing active cost evaluations to understand cost per dose and cost per community, in addition to cost effectiveness of the intervention. And so I think we'll have a lot more information over the next year. Our initial work is landing somewhere in the range of about $1 per dose delivered for this intervention, depending on what's included and what perspective you're taking. And of course, to date, Pfizer has been donating all of the azithromycin for the trachoma program. And so some of these analyses make that assumption that it would continue to be donated. And I think that is another big open question if Pfizer will be continuing on for this program as well.
Wonderful.
Thanks.
Paul, do you want to go ahead?
Oh, yeah, sorry. Are you closing? There's two quick questions then. One was, I guess it relates to health economics in a way. I mean, clearly these are also opportunities to be doing other things with these children. And I wonder what those opportunities have been so far, but I can see mass vaccination and other things. And the second comes back to the mechanism, and I'm sure we could spend many hours thinking about this, but you did show some nasopharyngeal colonization data, which was more about antimicrobial resistance rather than an impact on pathogens. But are there any data to show that before and after there's a reduction in pneumococcal carriage or meningococcal carriage and so on, to try and particularly thinking about the meningitis impact, which I think is incredible. Thank you.
Yes, so I'm realizing I forgot your first question as I was thinking about the second.
With other interventions.
Oh, absolutely. Yes, that's an excellent question. And there is a lot of talk about how best to integrate, like whether this should be implemented as a vertical program, as has been done with other neglected tropical diseases, or if it should begin as an integrated program. And if so, what programs should it consider integrating with? In Burkina Faso, there is currently a study called Marama that has integrated azithromycin distribution into the Child Health Day platform, which includes vitamin A supplementation, deworming distributions, and malnutrition screening as well. And that is also a platform being expanded in Niger currently. And so that's one that we're interested in continuing to explore, along with, there's a lot of interest in maybe seasonal malaria chemoprophylaxis or other community-based malaria distributions. And then of course, immunization campaigns, which tend to use the same format.
Do you want to just quickly say something about whether you've observed any difference in nasopharyngeal carriage if you've actually looked at that around meningococcus and pneumococcus?
Yes. And so in pneumococcus, we do see a reduction in carriage immediately after the distributions. That sort of, increases again over time. Our group has not looked at meningococcal carriage after, but I imagine others are.
So I'm going to talk a bit about the network, the chain network is doing quite a few different things, but I'm going to focus specifically on some of the sort of core mortality results, and then focus on antibiotic usage and AMR. And so the chain network was set up to answer some specific questions. And for those of you who are familiar with the NEO-OB study in neonates, there are some similarities, but chain is a little bit broader. So we've been sort of recognizing for a long time that the mortality rates in children who present with an acute illness have remained very high, despite sort of overall global reductions in child mortality. We see less cases, but when children become sick, they continue to have a high mortality. The guidelines are generally based on clinical syndromes with a few things like anthropometry and clinical features to classify children. But they don't tell us that much about the mechanism or what organisms are involved. They're a very crude way of describing illness and acting on illness. And then the third sort of feature that we're looking at is there's been an emerging recognition over the last few years that there's a considerable risk of post-discharge mortality. And so Chain looked at children aged 2 months to 2 years at 9 sites across Africa and South Asia, and you can see them there in the map. We're very proud to say that it's the first sort of large Gates-funded network that was coordinated from within Africa rather than being coordinated from the United States. We had a number of work packages. One was a large sort of cohort study looking at clinical, nutritional, demographic associations with mortality, both in hospital and after discharge. There was a social science work package going into households, interviewing mothers and clinicians as well, to really looking at sort of the social aspects of things that may contribute to mortality. And then there's a large systems biology study using numerous samples that we collected during the study, doing multiple omics to look at what the sort of mechanistic causes of mortality are. I'm really only going to talk about the first of those three. And in particular, I want to highlight that we wanted to find out about children who died despite following guidelines. So we audited and trained sites to follow guidelines, and therefore we use some actionable interventions. So the cohort enrolled children at admission to hospital. It actually assigned children to 3 strata by anthropometry, and the idea of that really was to make sure we had a good spectrum of risk, with the severely wasted or children with kwashiorkor in red there, having a known high risk, moderately wasted children having a known moderate risk, and non-wasted children having a known lower risk. But we also know that there's many other things that determine risk, but that gave us a spectrum. So, and then we closely followed children during monitoring their daily clinical signs, their treatment they were given, with again numerous clinical samples and being taken, either processed immediately or stored for later processing. They repeated the entire admission assessment, so all the clinical examination, all the bloods and everything, and we did home visits and monitored, did questionnaires for things like maternal mental health and wealth, and we visited households and did GPS mapping and plotting various things. And then we followed up children for 180 days after discharge, and for children who died in the this is just to illustrate the sort of very detailed data that we collected. And we actually asked sites to enroll at quite a slow pace in order to make sure that they could be 100% sort of complete on their data. And for interest for this audience, so you can see we collected sort of all the microbials that children received, all their clinical signs. So I'm going to jump straight in with some characteristics and some results of the main sort of mortality results, and these are already published. So we enrolled 3,101 children, median age of 11 months. We were quite surprised to see that the clinical profile in terms of the syndromes was very, very similar between these three nutritional strata. Maybe a little bit more diarrhea in the malnourished children, but really very, very similar. So children are not being admitted because of their nutritional status. They're being admitted because they're sick. So just to give some initial results, so we split the primary mortality analysis into what we call early mortality, which is admission to 30 days later, and then we separately looked at post-discharge mortality. If we look at the overall mortality curves, these were quite striking. I mean, not surprisingly, we kind of expected that the children who were more malnourished would have more mortality. So we see the red line with the severely malnourished children, which actually represents about 20% of all of the normal intake of these hospitals. So it's not an unusual characteristic. So about 20% of admissions have about a 20% mortality risk over the next 180 days. Then the moderately wasted group in blue, and there wasn't such good data on this, and we were interested to see about whether there's a significant difference between those and the non-wasted children, and there is. And I'd sort of highlight 2 things about these curves. One is obviously the very steep mortality in the early phase, and then secondly the fact that the curves don't flatten; they continue to just go up and up in a straight line. So there's a background mortality risk after discharge from hospital, which is sort of not abating. We for the early mortality and for the post-discharge mortality, we developed structural equation modeling because we wanted to look at the sort of underlying causes, then the sort of immediate effects, and then their effect on mortality. So in this diagram, you see things like HIV, chronic conditions, child nutritional exposures, caregiver characteristics, including things like mental health, mother's employment, education, things like that, and household factors, including things like income and water and sanitation and household density and things like that. And then also access to healthcare in terms of cost and means of transport and geographic distance to the nearest health facility and geographic distance to the study hospital. And overall, this is pretty predictive. This model is pretty predictive with a AUC of 0.81 down in the left corner. And what we see is that when we measure nutritional status, we're actually capturing a lot of those underlying risks, like underlying medical conditions, as well as the sort of underlying nutritional risks. But also we see that those underlying factors also had direct effects on mortality, which weren't sort of detected by measuring nutritional status and illness severity. Although we saw in the survival curves, it looked like the three nutritional groups were completely different. When we use that SEM model to predict individual children's chances of dying, and then we plotted this on a log scale, what you can see is that the groups are very overlapping. So there are some severely malnourished children with low risk of mortality, and there are some non-malnourished children with a high risk of mortality. And so we really wanted to understand what those other sort of risk factors for mortality were. Moving on to post-discharge mortality and also readmission, and we have published the post-discharge mortality. We're about to submit a paper which is more detail about readmission. Of the post-discharge, of all the deaths that occurred, and there was 350 deaths, 48% occurred post-discharge. And this again, this was quite surprising. There had been, previous systematic reviews which had shown a range of percentages, with sort of 50% being the sort of highest in terms of proportion of deaths occurring post-discharge. But those studies all had variable follow-up times and often had a lot of loss to follow up. And what we saw was that this, nearly half of all mortality was consistent across all three of the nutritional groups. It was also consistent across all of the 9 hospital sites. So it seems that this is very generalizable, that half of the mortality was occurring post-discharge. When we looked at the post-discharge deaths, we saw that the majority were occurring at home without readmission. But this was more common in the more malnourished children. But even in the non-wasted children, we have 41% of post-discharge deaths occurring at home. I'm not going to show any data, but we also did a sub-study looking at costs to families. And we found that even in sites where, in theory, medical care is free for under 5s, that families were having to spend nearly a month's household income on the admission. And we see cost as one of the major barriers to readmission. We also added a new layer into our structural equation model, which looked at what happened during and at the end of the admission period. So we added boxes in the middle for being discharged against medical advice, which occurred in 7% of children and had a significant association with post-discharge mortality. We were surprised to see that admission duration did not have an association. Lots of things predicted admission duration, but admission duration itself did not significantly predict post-discharge mortality. We saw that the change in nutritional status during admission and the change in the signs of illness severity were also predictive of mortality, but they were largely governed by those characteristics at admission. And the interesting thing, looking down on the bottom left, is that the area under the ROC curve, bootstrapped 1,000 times, was 0.81, which is the same as for the early mortality. So what this means is that the 180-day discharge after 180-day post-discharge mortality was as predictable as the early mortality, and that hadn't been shown before. One of the things that we did for both early mortality at admission and for post-discharge mortality at discharge was ask clinicians to rate what they thought the chances of the child were dying are after they filled in the clinical examination and the immediate laboratory tests questionnaire. And we found that clinicians' sort of gestalt impression on a Likert scale was actually pretty poor. So that had an area under the receiver operating characteristic curve of 0.56. And as many of you may know, 0.5 is what you get when you toss a coin. So it's only barely better than tossing a coin. And this made us think that you really needed formal, some form of formal assessment, particularly at discharge, which doesn't currently exist in guidelines. When we looked at hospital readmission, we were really surprised to see that this followed a completely different epidemiological pattern, and there was no significant difference between the 3 nutritional groups. What this means, we think, is that in the non-wasted group, there were lots of readmissions and relatively few deaths, and in both of the malnourished groups, there were many more deaths and relatively fewer per death readmissions, and possibly again relating to the fact that cost and sort of access were problems for readmission. But we also saw in the social science work that often the undernourished children felt badly treated by hospital staff and also reluctant to come back for that reason. We noticed that across sites there was both variation in the number of readmissions as well as the variation in the post-discharge mortality. And so we developed a sort of an index of sort of willingness to come back to hospital when the child's seriously ill by taking the ratio of the number of post-discharge, the number of readmissions to the number of post-discharge deaths. And you see the third one down there is Migori, which is in Western Kenya, which is our highest mortality site. And we literally had one readmission per post-discharge death. So this is kind of, we found this quite a shockingly low figure, that they're just, people were just simply not coming back. Whereas in Dhaka and MATLAB in Bangladesh, there was about 10 readmissions per death. The Dhaka and MATLAB sites are being run by the ICDDRB unit, and they actually run sort of a field worker program with community health workers, and we believe that contact may have improved the people's ability to come back to hospital when children became unwell again after discharge. We also noticed in the verbal autopsies that we did on the post-discharge deaths that children were often dying quite soon after parents were noticing that there was something wrong. And we felt that this echoed our experiences in hospital, where particularly with the undernourished children, they could, they look quite well in the ward round in the morning, and then sort of later in the day, you're told that this child has died, and you're sort of wondering what you could have spotted. The children change condition extremely quickly, in the same way that sort of immunodeficient children do in high-income countries. So I'm going to talk a little bit about antimicrobial usage and antimicrobial resistance, and this is work entirely done by Caroline Tagoy, who's my and Nicole Storso DPhil student in Oxford, and she's done a wonderful job of putting this data together and analysing it. So we first looked at antibiotic use in the week prior to admission and saw this was very common. Again, the lowest in that Western Kenya site with the highest overall mortality, and lower in the Bangladesh sites, which had lower overall and higher in the Bangladesh sites, which had lower overall mortality, with a range of about 30% to about 60% of children receiving antibiotics before admission. When we looked at the antibiotic usage while in hospital, we used the WHO aware categorization, and we saw, really no use of reserve antibiotics in these hospitals, except in Karachi, in Pakistan, and also a pretty similar use of fairly similar use of watch antibiotics across all these hospitals, again, except in Karachi in Pakistan, who are using watch as more often as first-line agents, often combined with an access antibiotic. You can see the lighter part of the bars, which are at the top of each bar, and they show the antibiotics which were started after the first 48 hours. And so you can see that, there's obviously relatively little starting of access antibiotics as expected after the first 48 hours. But actually, even the majority of watch antibiotics are being started before the first 48 hours. And we were kind of struck by how little sort of switching was going on. When we looked at that between the three nutritional strata, we were incredibly surprised to see that essentially they look more or less the same, perhaps with slightly more access and slightly less watch use in the severely malnourished children, which we thought was really surprising because they stay in hospital much longer, they're generally much sicker. They have a much higher rate of hospital-acquired infection, and this is the group who you would really expect to be receiving watch and even potentially, reserve antibiotics. And I think thinking that through, we felt that this is largely driven by people trying to adhere to the WHO guidelines, which essentially don't have much advice for escalating and de-escalating antibiotics. So this seemed to be sort of contrary to previous reports where people were concerned of overuse of antibiotics, and we felt that in these settings we were really trying to follow guidelines. By following the guidelines, there's probably an underuse of antibiotic switching. And then that's sort of shown by when we looked at switching in detail, across the sort of 2 weeks or more of admission. There's relatively few of the green access area going down into the light green, which is at watch plus access, or into the yellow area, which is only watch. Most of the greens are just going to another green, or they're going up to the white group at the top, which is being discharged. And also, we noted that a relatively small proportion of children admitted who received no antibiotics, 10% in the first 48 hours, dropping to 8% in 72 hours, and then really only a handful of percent after that. So almost every child is receiving antibiotics. I won't go into details of the types of antibiotics just because of time, but we did look at the factors associated with receiving watch antibiotics. And not surprisingly, prior hospital admission came up, but surprisingly, nutritional status didn't come up, danger signs didn't come up, but suspected sepsis or suspected meningitis encephalopathy did come up, which I guess is reasonably expected. Chronic conditions, and again, duration of admission, which is reasonably expected. So I think there's a number of things there which kind of seem sensible, but perhaps the sort of severity of illness signs and the severity of nutritional deficit not being really picked up as potential reasons to think about switching. So then we also did a sub-study in the three Kenyan sites, and they're very different sites. One's this poor community on the shores of Lake Victoria, Migori. One's Nairobi with mainly informal settlement dwellers, and one on the coast in Kilifi. So we did an AMR sub-study, but primarily looking at AMR carriage, but also collecting invasive isolates, and also, which we did at all sites, collecting well children in the from the same age within the same communities. And in these sites, we took swabs at every visit to investigate the background rate and acquisition and loss of AMR in rectal samples. So these are the results of that. So we saw in the communities, they're fairly similar, with fairly similar level of sort of 15 or 20% of the well community children carrying ESBL, which jumps up to sort of 30 or 40% in the admissions, and not perhaps surprisingly because of antibiotic usage. But then another big jump by the time of discharge. So we're looking at sort of 60, 70, 80%. Who are carrying ESBL by the time of discharge. We were really interested to see how long that acquired ESBL would last, and in fact, by day 180, it had not yet come down to the sort of the same level of as in the well community. So it takes a long time to disappear. We saw a particularly high rate of ESBL when we took swabs at the time of readmission to hospital. And given that many of those readmissions occurred quite late on, this rate was much higher than we were seeing in the background, that background declining rate. And that's partly due to, again, antibiotics being used prior to hospital readmission. And also we've found, as I'll show in a moment, that having acquired ESBL was associated with post-discharge mortality and readmission. So we also looked at carbapenem resistance in those samples. I mean, there was really no carbapenems used in our cohort, but there were very occasional carbapenems being used in the hospital in Nairobi, and we saw sort of very little admission, but about 6% of Nairobi children carrying carbapenem resistance at discharge, and a similar 6 or 8% carrying carbapenem resistance at the time of readmission. And we felt that was pretty high. Looking at factors associated with ESBL carriage at admission, prior hospital admission, pre-hospital antibiotics, and pneumonia. Interestingly, not age, not HIV, not chronic conditions, which we were slightly surprised to see. And then looking at acquisition in hospital, this is children who were negative for ESBL at admission, but became positive for ESBL by the time of discharge. Sex, which we were initially surprised, but looking at the literature, other studies have also reported that female children are more likely to acquire ESBL in hospital. Now we see things like HIV, chronic conditions, and not surprisingly, length of hospital stay and antibiotic classes being associated with acquisition. We also looked at the persistence to day 180, which had very somewhat similar predictive factors to the acquisition in hospital, but also together with readmission, perhaps not surprisingly, but interestingly, the home population density, so certainly living in those Nairobi slums, was associated with persistence to day 180. So a lot of people have tried to sort of associate the presence of antimicrobial resistance with mortality, and it's not generally that successful. And the problem is that people with resistance tend to be a bit different from people without resistance, and it's very difficult to adjust for all those confounders. So we took a slightly different approach, but not just taking anybody with resistance, but by taking children who had started at admission with no resistance for ESBL and who had acquired ESBL during admission, and then adjusting for everything we could think possibly could have influenced that. And we did see a significant association with post-discharge death or readmission. Caroline's gone on to sequence a lot of these isolates, and we've also been sequencing hospital environmental swabs, but which I won't talk about today. This is from E. coli, from rectal swabs and from invasive isolates. What we saw here was a very large diversity of E. coli, and that the rectal swabs, which are shown in orange in the inner ring, were rather also very diverse and rather similar to the blood culture isolates, which are coloured blue in the inner ring. And we saw several incidents where these were clustered together, which suggests that the kind of ST types that we're seeing in the rectal swabs are also those which are causing invasive disease, which kind of supports our thought about this potentially being a risk factor for post-discharge mortality. And then briefly, we've also looked at the sequence those and looked at the genes in the E. coli which were being carried. CTX-M15, comes out as our sort of leading cause of ESBL. A little bit of NDM5 in this case, and down on the bottom right, some markers of aminoglycoside resistance, a little bit of FOS-A in the middle of the left there. So a fair sort of spread of resistance. I mean, surprising, to see really quite a lot of those aminoglycoside resistance genes. So in summary, we felt that the current syndrome-based management does not really reflect individual risk, and we need a more risk-based approach. There's a really major post-discharge mortality risk, which is seen, right across all the facilities we saw across all new nutritional groups. But interestingly, that post-discharge mortality is predictable. We saw that readmission has a different epidemiology, and we actually saw from our sort of comparison at sites that readmission isn't something we want to prevent; it's something we want to promote, because it seems to be life-saving rather than a problem. So if we were implementing a post-discharge intervention, one of the things we might want to do is recognition and early readmission when there's a problem. We strongly felt that the current syndromic WHO guidelines were inhibiting appropriate antimicrobial use with very poor sort of switching, and we also felt that AMR acquisition is a likely driver of post-discharge mortality, which is interesting. And I think the other scenarios for post-discharge mortality obviously are incomplete treatment, and that may also be an effect of AMR. But I think something that you've acquired in hospital is a potentially important and preventable cause of AMR, and it's definitely a reason why we shouldn't be trying to prevent post-discharge mortality by keeping children in hospital longer, unless there's some very specific action that we're taking during that longer admission. So the next steps, we're talking a lot with WHO about developing risk-based management guidelines. Particularly also for low-risk children. We thought about 30% of the children could have been discharged probably after 24 hours and saving an enormous number of child bed days. We think that, it happened in NEOSEP, It's more about antimicrobial care pathways than individual head-to-head comparisons, which are needed in trials. And then there's a whole raft of post-discharge interventions, and some of these we're discussing now with Gates Foundation. Some of them are sort of part of other applications for funding, particularly some health systems components, down referral, somebody being responsible for high-risk children after discharge, maternal support, including cash transfer, links to health services, training for mothers and clinicians on post-discharge risks, training for mothers on recognition of danger signs, and then some biological interventions. But many of those are being driven by the nested systems biology study. But we are talking to our collaborators in Sanger to look at the potential for use of probiotics to try and push out those newly acquired, hospital-acquired resistant isolates. I think that's all for now, and you can visit our website at www.chainetwork.org. Thank you.